Well, hello, listeners, and welcome back to Our Experts. I am Carol Matichka, your host, bringing you interesting perspectives in pharmacy, and today is absolutely no exception. We are very fortunate to have with us today Dr. Robin Moorman Li, who is a pain expert. She has been an expert in the field for over 20 years. And really, I'm very excited about our podcast actually today because she's going to be talking to us a lot about really what's new in the pain world, but also what she's seen and sort of some of the history that we've seen in regards to pain management. So please welcome Dr. Moorman Li.
Thank you for having me.
Yeah, absolutely. Thank you for coming. So before we get into any other questions, one of the things I like to do is make sure that our audience gets to know you a little bit. So if you could share with the audience how you got into pain management. Well, and really pharmacy.
In pharmacy in general.
Yeah.
So it's kind of a long story, but I'll make it short. So basically, I started out in business. I loved accounting and excelled in it. So I went to Kansas State University and took some business classes and realized that maybe microeconomics and macroeconomics just weren't my thing. And so I went to a counselor and asked him, what about healthcare areas? Because I did grow up going to visit my mom at the hospital. She was a diabetes educator, and I got to see her educating patients all the time. And I thought that'd be a lot of fun. And I was very interested in diabetes management. And so I started looking at possibly med school, pharmacy school, med tech, and, just all kinds of different areas. Mm-hmm. And so I looked at the prereqs and I decided to try pharmacy. So I got a job in it. And I worked at a place called Barry's Drug Center, which was an independent. And he was on the State Board of Pharmacy. So I got to hear his world about that, work with the patients in an independent pharmacy, and I fell in love.
Oh, that's awesome.
So that's how I got to pharmacy world and applied and got into University of Kansas School of Pharmacy, got my PharmD. And interesting enough, I have no sense of direction. And we had won a competition and had to go to Vegas to the mid-year. And I made a wrong turn because I just don't know where I'm going. And I ran into something called a residency forum.
Oh,
and
okay.
I went up to somebody and said, what's a residency? Because I was just second year at that time. And they were like, how do you not know what a residency is? And so I ended up learning about that. And I decided to apply for a residency and went to Mississippi Medical Center. And it was in Jackson where our site was. Okay. And I had some introductions with pain management there where there was unfortunately a patient that died from a parodying overdose. And it was very interesting to me. She had sickle cell, and I had found out that her pain wasn't well controlled, and she was going to different ERs. And I started looking more into pain management, and I realized what an opportunity pharmacists have to educate patients on dangers of opioids, of course, but more about how to treat pain so that we can get more comfort level with these different types of pain issues. And so that's how it started. And I was recruited to come over at UF Health Jacksonville, and I started with some primary care clinic.
Fantastic.
Yeah.
And here you are today, which
here
is amazing.
I am.
So you've been practicing quite a bit of time now here at UF Health Jax. Tell us some information about what your current practice involves.
Okay, so when I first started here, I was full-time working as an ambulatory care practitioner, and then I came to the college at University of Florida College of Pharmacy, and I did some work over at River Garden and did some geriatric pain management. Mm-hmm. A lot of people that had knee replacements, and then I came back into UF Health Jacksonville, where I currently am. I work in two different clinics, and so one clinic I work with anesthesiologists, and me and Joe Camilleri, which is my partner, we work together to help do medical management. So a lot of these patients are on opioid therapy, so we're monitoring those patients, we're educating them a lot, and then just doing frequent follow-ups. The other clinic is CB McIntosh, which is a clinic that is a pharmacist-run clinic that is under the referral process of primary care physicians. And so we, again, see patients do medical management. Even a lot of our patients over there are not on opioid therapy. We do non-opioid therapy, non-pharmacological management. So it's really focused on, again, that education component.
Gotcha. That's great. And so many are very likely to understand a little bit about the fentanyl crisis that we're really dealing with. We used to say opioid crisis, but really we're seeing so much fentanyl right now. So we understand the history as well. I think a lot of people understand the history and how we got to this point. But if you can share a little bit from your perspective and thoughts on how we got to where we are today.
Yeah, I think it's very interesting to take kind of a look at pain management in general and look at the history of where we've been with our treatment plan. Mm-hmm. And so when I came into it, it was early 2000s. And I really jumped into the deep zone of this because they were dealing with the pain as the fifth vital sign.
Right.
And there was a lot of almost suggestion that we utilize opioids more to try to relieve some of this pain, even in the non-malignant pain type of situation. And there was some literature that suggested that would be okay. And there was some literature out there that said, you know what, the addiction potential is lower. Right. And I think that really kind of started driving a lot more. Now, the interesting thing then, as well as now, we don't have enough pain physicians for all the pain patients that we have. And so primary care really became that area where patients were going to, and these primary care providers were trying to help these patients by prescribing these opioids. And, when you think about it, you think about pendulums. And so the pendulum at that point was where a lot of people were put on opioid therapy because of the issues that were going on. We also had the pharmaceutical industry that kind of jumped into that. You can watch pretty much all the documentaries that have been released over the last few years on that.
Yeah.
And with that, they talked about the long-acting opioids that maybe will decrease addiction potential. We know all now that is not appropriate. We know that addiction potential is high with opioids, as well as a lot of other risks associated with opioid therapy. And so as we've moved through that, when you think about the number of patients that deal with chronic pain, right now the CDC estimates that we've got about 51 million people dealing with some sort of chronic pain.
In the U.S.?
In the U.S. alone.
Yeah.
And, that really makes you stop and think, wow, we've got to figure something out. Mm-hmm. And when you also look at the opioid issue, you can go to the CDC website and they talk about the waves of opioid overdoses. So when you look back at the history, we're looking at 1999, about to 2010, mm-hmm. we really had more of the opioid overdoses that were related to opioid prescription overdoses. And one thing I want to mention is it's not usually just one drug. It's going to be a combination of many drugs. And then we moved into this second wave that started about 2010. And that's really was attributed to more of the heroin overdoses. Mm-hmm. Then we moved into the third wave, and that was about 2013. And that's where we saw the fentanyl start to really show up. And we had the opioid epidemic that was really coined in 2017. That's when they really officially said opioid epidemic. Now, interesting enough and scary that we do have a fourth wave that's been proposed in the literature where they're talking about the fentanyl still staying there, but it's a combination of fentanyl plus cocaine and methamphetamines. Mm-hmm. And so that's very scary that we have these stimulants that are coming in there as well. So we have this huge problem with the opioids. And there's been new CDC guidelines that have come out. 2016 was the first round, and now we have the 2022 CDC opioid prescribing guidelines. Mm-hmm. And what you see now is there's a drive towards really, there are times that opioids could be used, but we need to look at the patient from a holistic standpoint, look at the biopsychosocial. So what does that mean? Well, we're looking at the biology part, but we also have to consider the psychology part. Stress, insomnia is such an issue with chronic pain. And of course, the social factors, because all of it plays into that perception of pain and the experience of pain that patients experience. So now the whole change is gone are the days when we were just looking towards an opioid to knock out pain, because we know opioids aren't that great anyway. In regards to knocking out pain, we're looking at multimodal, multidisciplinary types of treatment for these patients to figure out what's going to work for them. And like I teach my patients and my students, in math, 1 + 1 + 1 is 3. But in the pain world, when we add these different adjuvants, non-pharmacological, all these different therapies, as well as multidisciplinary types of treatment like physical therapy, maybe 1 + 1 + 1 is 5 because we get that additive effect. Right. So that's where we are now compared to where it was back in the day.
That's fantastic. Thank you for that overview. And you said non-pharmacological. So can you kind of tell our audience what you mean by non-pharmacological?
Sure.
treatments?
So non-pharmacological is kind of this, I call it the buffet. There's a lot of different things that we can use. We could do things such as guided imagery, deep breathing exercises, because we're trying to calm this whole nervous system. We're trying to calm everything
What's guided
down.
imagery?
Guided imagery is where, like I teach my patients, you almost see a vision of something. I tell them to think about their favorite day in their life and play it as a movie, and that they can kind of see that and then start doing some deep breathing. So again, you're bringing those happy thoughts in that are calming,
Right.
do the deep breathing with it. And then we do something like progressive relaxation, where you imagine all that stress and pain and stuff at the top of your head and then work your way down and try to push it out. And it's just a way to try to learn how to relax your body all the way through.
Oh, wow.
There's other things as well as acupuncture, for example.
Sure.
That's been shown to be very helpful. Tai Chi, other types of movements. Exercise is so important, and that's very difficult. When you hurt, do you really want to move?
Right.
But it's so important that you continue to make those muscles strong, because deconditioning is so bad on the body. And that's something that I tell the patients, when your muscles are not being used, they're crying out. And how they cry out and say, move me, is to make you more achy. And so even if it's baby steps, like walking to the mailbox once a day, it's a start.
Right.
And that's what we have to do to keep encouraging these patients.
Wow, thank you. That's fascinating. So then where do opioids fit in when we talk about pain management? I understand all the non-pharmacological, completely makes sense to me. Where do we fit now opioids in our chronic pain patients?
Great question. So the first thing you have to say is that every patient's different. We need to treat them as an individual and see what their needs are, but we are going to look towards those other things such as non-opioids, adjuvants, or non-pharmacological treatments first, and then maybe look at opioids. There are some patients that are good candidates for an opioid trial. Okay. And I stress that because just because you're prescribed an opioid doesn't mean you're going to stay on it the rest of your life. Our goal when we're looking at chronic pain management is, we'll look at those pain numbers. It's so hard to rate your pain. As you're sitting here right now, how do you rate your pain? Right. But looking at activity, looking at quality of life, because if you're starting to get moving again and starting to be active and engaging in life, then we know that we're on the right track. If you start an opioid, for example, and that's not happening and you're laying on the couch taking pills, that's probably not a good answer for you. And that's right. So important. It's a very difficult conversation, but I think it's really important that we remind patients that opioids are not this end-all be-all, that it's going to eliminate their pain, because number one, it doesn't. And secondly is that it really does, it takes the edge off. Mm-hmm. But when you look at the studies, it's not doing much. And long-term, we don't see a lot of impact with opioid therapy. But I stress again that there are patients that opioids are possible to be considered as a trial. And if they are succeeding in that and doing well and we're seeing increase in activity, then that could be something for them. But it's definitely not first line.
Gotcha. And, we talk a lot about pain, and that was one of the things, fifth vital sign, and people shouldn't have pain. But pain isn't necessarily a bad thing. Can you talk to that a little bit?
Sure. Pain is a warning system.
Right.
Just like if you put your hand on the stove, your body says, get that off. Because if not, you're going to burn your hand really bad. And so there are times that pain is good. But unfortunately, we have those changes that create that chronic type of situation. But then we have to take that step back and say, what's all playing into this? And it goes back to looking at that biopsychosocial kind of model to figure out how we can try to manage that pain and work through that and kind of almost learn a new normal when you do have an injury. Let's say you have a car accident and you are dealing with some severe chronic back pain. We can create a new normal to where you continue to live. If you lay down all the time and again get further deconditioned, you're going to make your condition worse. So we have to work together to try to find out what's right for you.
That makes sense for sure. So you're very involved in PAMI. We haven't talked about that yet. Mm-hmm. What does PAMI stand for?
Oh, goodness. I always forget
Pain
that.
Assessment and Management
Yes.
Initiative, I
always have
believe.
to think about it.
Yeah, I gotcha.
PAMI is PAMI to me.
Right,
So, yes.
absolutely. So what is that? I'm sure our audience would love to hear a little bit more about
Yes.
that.
So PAMI is a group of multidisciplinary practitioners that have worked together to come up with different ways of educating patients as well as providers on the proper use of medications, but with the focus on non-pharmacological and non-opioid treatment. And so I've brought some show and tell today because
I love it.
these are some of the things that we do. We actually have PAMI carts that are located through the hospital setting as well as the ambulatory setting that we use as different areas to educate patients. And so I'm going to start over here and talk a little bit about this.
Okay.
This is a car with 4 flat tires is basically what we're looking at. And you can actually find this on the ACPA website. But what we're thinking about here, think about a time that you have a car that has 4 flat tires. If you air up one tire, how far are you going?
Not
Nowhere, right? And so when you think about healthcare in general, you think about pain, you think about other disease states, we've got to look at all aspects that are playing into that disease state, including chronic pain issues, to figure out how we can air up all 4 tires. So we're not just thinking about the physical aspects of the pain, but the psychosocial part, and tying all that in to come up with a more comprehensive treatment plan and air up all our tires. So I use this as an educational point for patients to kind of see, okay, I am experiencing pain from all kinds of things. If I have a fight with my loved one, for example, I notice my pain's higher. And so we encourage them to journal as well, because they might see certain activities or certain stressors actually increase their pain. And them learning about that can also give us some more tools to teach them to how to decrease that as well.
Very good.
So insomnia is a huge problem in chronic pain management. If you've ever had an acute injury, for example, think about how hard it was to sleep when you hurt. I mean, it's just difficult. And so somebody that's been dealing with this for years and years, you can imagine that insomnia is very common, and that can lead to stress. I'm sure each of us have had those insomniac nights where we're just looking at the clock and saying, are you kidding me?
Unfortunately.
Another hour's gone by.
Yeah.
And so lavender can be one of those. This is aromatherapy, and there's been some good literature, especially with the lavender. And so I have patients that will use this to help with kind of that calming and healing. Of course, we have our cold and heat packs. So these are kind of nice. Patients love these. So you can put it in the freezer, of course, or you can heat it up in the microwave. So I give all that instruction. I think in pharmacist worlds, it's so important that we educate patients on the proper use of this in terms of how long, how important it is to wrap up this package to protect your skin. So I always say, find that old t-shirt that's the really thin one we all have, and wrap that around and put it on, and then only do it for a certain amount of time. And we talk through all that so that they're safe. I always talk about heat pads too, because those are very dangerous. There are many reports of patients that fall asleep with the heating pad and they wake up with a nice burn. And of course, the fire risk as well. So these are always nice because they're going to cool off if you fall asleep. So that's just another thing. AccuLeaf is another one. This is a acupressure type of thing that will help with headaches. So I see a lot of patients that suffer from migraines, and some of my patients feel like this really helps as well.
Oh, that's great.
The last one I think is one of my patients' favorites, and mine too. What this is a patient education activity book, and obviously I'm not going to go through it all today, but I will tell you that it's online too. You can find it on the PAMI website. If you go to Google and just type in UF Health Jacksonville PAMI, you'll be able to pull this up.
But we'll put that in the show notes too.
We'll put it in the show notes, okay? Yep. So there's a table of contents here, but basically we're talking about not only what is pain and how to deal with it, but how do you track pain? How do you learn how to balance your activities so you don't burn yourself out in one day and then down for 2 days just to recover? Sure. Also, we talk about some of the diets, anti-inflammatory diets or something that can be, and how to meal plan with that. How to set goals. That's so important. What are we going to do and how are we going to get better? And this has been really interesting. And I give this to my patients for homework to go through and work through and come back and talk to me about it. Yeah. And then a lot of them I have bring their journals with them, and they'll rate like how their pains were, what they were taking, what medications. For example, a short-acting opioid. I want to know, okay, what was your pain when you took it? 1 hour later, what is your pain? Because then I can see if they're getting any response from that also. So this gives me a lot more information as a clinician to help them when we figure out what treatment options are working for them and what ones we need to pivot on.
Oh, that's fantastic. So one other thing that you have in your tool belt is you're actually trained in regards to health and wellness. You're a health and wellness coach. So can you talk to us a little bit about what that entails and how you work with your patients?
Sure. So, again, I made a wrong turn. I go to Pain Week periodically, which is a multidisciplinary pain conference that is held right after Labor Day out in Vegas. And I made a wrong turn into this session, and it looked kind of interesting. And it was about coaching pain management patients and trying to figure out what is the best way to approach that. And I ended up joining that program and taking classes. And it was a long process to where I ended up qualifying for the national boards, and I'm actually nationally board certified in health and wellness coaching.
Congratulations. Yeah.
But I did it because I saw how many patients were kind of almost stuck. Like they hadn't improved. And how can I, as a clinician, get more skills to help meet them in the middle and try to see how we can make them move further. And the coaching was amazing because it teaches you how to work with patients to encourage them. I call it motivational interviewing on steroids because it really teaches you how to talk to the patients to pull out what their interests are, what their dreams are, and then working with them so they see that they do have the power, that they can make changes in their life. Even if their baby changes, they can move up into a next stage. And I always say, a little win adds up to a victory. And so it's been a lot of fun because I don't just use it in pain management. I use it in smoking cessation. I've used it in diabetes education. I've used it with our students because we all have areas where we need to make changes in our life for the better.
Absolutely.
And so finding ways to get people to explore that and get confidence in themselves has been very rewarding in using these skills.
That is absolutely fantastic. So, you've seen all these changes over the past 2 to 3 decades, really in regards to the treatment of pain. And I love what you're doing with all of our patients here, as well as our students. You do a lot for our students. But where do you see pain management going in the next, let's say, couple of decades or so?
So it's going to be very interesting. Of course, we're trying to sway away from the opioid therapy and, again, try to use the lowest amount of opioid possible. I think a lot of the interventional techniques that they're working on could get us even further. When reading about some of the things they're doing, it's pretty amazing. They're looking at neuromodulation as something that's basically where they're using currents to stimulate pain. So some of you might have heard of various types of implants that they'll do where they're stimulators and they do electrical currents.
Right.
They're growing that and using it in different areas to help with pain management. And interesting enough, when I was doing some research just to see where they were on it, they're even doing things with diabetic peripheral neuropathy, which is such a big one. The other thing
That's
they're using—
challenging condition.
It is very challenging. And then regenerative medicine, and they're using basically biomaterials where they're trying to figure out how they can do different types of injections in these joints, and they might be able to help the cartilage or the back. And so that's been very interesting. In terms of the medication world, they're looking at like the sodium channel blockers, but they're really working very hard in trying to figure out ways that we can decrease pain experience without that side effect or issues with opioid therapy.
Wow, that is fascinating. So those injections, that's like cell therapy of some degree, stem cell therapy as well? Okay.
Some of that they're doing. Okay. And of course, one thing I left out of some of the treatment plan is that we are doing a lot of injection therapy where a lot of patients get injections in their knees and their backs, and that's what my anesthesiologists do. So we try to do that as a comprehensive pain care where we're not just focused on the medication therapy. Hopefully we can find that those injections will help decrease some of that pain, and it sometimes has steroids in it and whatnot, and then we can rely less on medication therapy.
Yeah, and it's focused right in that area.
Yep, exactly.
That's fantastic. So do you have any advice then for our listeners who are out there? Maybe they're interested in pursuing a career in pain management. It's such a fascinating field. What would you say to them?
Well, I'd say, first of all, if you are practicing in healthcare at all, you already are doing pain management. I always tell my students you can run, but you can't hide from pain.
True.
Because when you start thinking about disease states, it's very hard to come up with ones that do not have pain involved in them. My students, they've come up with rosacea, but even that can give you some pain. Sure. So they have a really hard time, and I challenge them every year for that. So I think every clinician should really work on learning more about what we can do to help our patients. As you see with all of this, the non-pharmacological and just the coaching and the education that we can provide patients to get healthier. I heard just recently, it was on a podcast, they were talking about how important it is that we keep our muscles strong. Mm-hmm. And the fall risk goes up as we get older, of course. And part of that is because our muscles are getting weaker. And so when you're working with patients that are in their 50s, 60s, 70s, how important it is to stay active. Even if it hurts, we could do baby steps. You know, like I mentioned before, walking out to the mailbox once a day, just make that a goal. And that might help decrease fall risk because we know that falls increase mortality. The other thing I would just recommend is with patients that are dealing with opioid therapy, really monitoring them, talking to them about the risks associated with that. Look at the drug-drug interactions because there's a lot of problems with that. And I always say, if somebody has an opioid in their house, Narcan should be there too. And educating patients, not only patients, but their family members on Narcan, and doing it in a way that doesn't alienate them. So start out just asking them, do you have a fire alarm in your house? If they don't, we have another discussion, but right. Which happens sometimes. Right. But say, well, if you have a fire alarm, do you want a fire? And they're like, of course not. I said, okay, well, guess what? Narcan is going to be our fire alarm for opioids. And this is what happens if opioids get too high for whatever reason. And then we go through the whole process and how important it is to call 911. Right. And I think every healthcare provider really should be versed in that, because if they see that a patient does have an opioid, or they even ask, do you have opioids in your house? Because we know that people like to store them away and hide them for a rainy day, right. Which is very dangerous. But that way, at least we have something if something goes horribly wrong.
Absolutely.
So,
and you know, with pharmacists being the most accessible healthcare providers, truly we can make such a huge impact on pain management. Just with everything you've been talking about here, I think this is really meaningful for a lot of people listening. So thank you for all of that.
Absolutely. I'll add real quick,
Sure.
Tying into if you want to go into pain management and specialize, there are residencies that are available. They also have pain management stewardships now in the hospitals. And again, that's working with just trying to utilize all these different therapies. So we have a program over here at UF Health that has been developed over time. So there are a lot of opportunities in this area. But again, I think we all have opportunities to make a difference in this area.
Sure, absolutely. Thank you. And we can share information again in the show notes about that and their ability to look information up here. So thank you for sharing that. So we really want to thank you, Dr. Moorman Li, for coming on to our podcast today. This has been absolutely amazing. I just, everybody really appreciates all the effort and the years you've put into treating patients with pain. I think that's absolutely amazing. And just before we go, is there anything you want to leave us with? Are there any last minute parting words that you would like to leave?
So I guess I will say the biggest thing as clinicians, we've got to listen to our patients. We need to make sure to treat each one individually and meet them where they are, and try to work on goals that they want to achieve, not what we want to achieve. And if we all do that, I think we're going to have a better outcome, and then celebrate those wins with them and remind them that those baby wins will be a victory. So if we can all do that, I think we're going to have even a better outcome for our patients.
Oh, I love it. Perfect way to end it. So thank you so much for meeting with us today. And as always, thank you for listening. Subscribe to our YouTube channel as well as to our podcast. And we'd love to hear from you. If you have any comments or suggestions for things you'd like to hear, please make sure you send that our way. And take care, everyone.